here are my disclosures. I will start by the definition of myopathy and muscular dystrophies. Myopathy is a generic term used to indicate any type of muscle disease. Muscular dystrophies or dystrophic myopathies are genetically determined conditions characterized by progressive muscle weakness, muscle fiber generation with replacement of fibers by connective tissue and fat. Here's a normal muscle biopsy. You can see that the muscle fibers have more or less the same size. You don't have significant variability. You don't see any fibers degenerating, and you don't see any excessive amounts of connective tissue in between the muscle fibers. Here's a fiber from a child who has a congenital myopathy known as Nemelin rod myopathy. You can see that the architecture of the fibers is preserved. You don't see fiber degeneration. You don't see accumulation of connective tissue, but you do see those inclusions known as Nemelin rods, but it is not a muscular dystrophy. This is a biopsy from a patient who has Duchenne muscular dystrophy. You can see that there is significant variability in the fiber size. Some fibers are large, some fibers are smaller. You have fibers degenerating with accumulation of inflammatory cells, and also you have significant connective tissue, amounts of connective tissue between the muscle fibers, but also in between the fascicles. How does a myopathy present? It can present with generalized proximal, distal, or focal weakness. If you have a child, he or she may have low muscle tone, hypotonia, with or without suppressed tendon reflexes. You may have fatigability. Sometimes you have rhabdomyolysis with myoglobinuria. Some of these patients, they have exercise intolerance, and in certain conditions, they can have myotonia and or periodic paralysis. This is what we knew more or less about muscular dystrophies back in 1885 as far as clinical pattern and inheritance pattern is concerned. We had a number of dystrophies with different names like Duchenne, Becker, Emmett-Dreyfus, and so on. And we knew the mode of inheritance. For example, X-linked recessive for Duchenne muscular dystrophy, autosomal recessive for limb-girdle muscular dystrophy, or autosomal dominant for myotonic dystrophy. But this is more or less the extent of what we knew at that time. And the laboratory investigation was limited to measuring serum enzymes like CPK and aldolase. We used to order electromyography and reproduction studies, and also we used to order muscle biopsies. By using these diagnostic modalities in conjunction with the clinical presentation, we're able to make a clinical diagnosis. Things changed in the late 1980s following the chromosomal localization of the Duchenne-Becker muscular dystrophy gene on chromosome X at XP21. And the gene which is mutated in this muscular dystrophies was cloned in 1986 at Boston Children's Hospital and also University of Toronto. And a year later, the protein product dystrophin was characterized again at Boston Children's Hospital by Luke Kunkel's laboratory. Following that, we're able to quantitate the amounts of dystrophin in muscle tissue by performing Western blot analysis and also immunohistochemistry, and detect mutations in the DMD gene by cellular blot analysis, PCR, or sequencing of the gene. And I will start with Duchenne muscular dystrophy. This is one of the most common forms of muscular dystrophy. with an incidence of about in 1 in 5,000 live births. And with onset before the age of 5 years, these patients have proximal weakness that follows a limb-girdle pattern, legs more than arms. They're unable to walk after the age of 13 years. They may develop cardiomyopathy, some degree of cognitive impairment, and most of them die in the second or third decade. And if you check a CPK, it's usually pretty high, even at birth, with values more than 10 to 50 times the upper limit of normal. So this is the clinical definition, and the time of wheelchair dependency so is critical because, again, most of these patients do not actually walk beyond the age of 13 years. And this is an image of a boy with Duchenne muscular dystrophy with a typical enlargement of the calves. This is known as pseudohypertrophy. And these patients have what's known as the Gower sign. We can see the child trying to get up from the floor actually has to climb up the thighs, support himself with one or both hands on the thighs and then rise to the standing position. So a very typical indicator of proximal weakness in a child who has Duchenne muscular dystrophy. We have to be careful because younger children, let's say under the age of 18 months, sometimes they appear as they have a Gower sign, when in fact they do not. And then we have another phenotype known as Becker muscular dystrophy, with onset usually after the age of 5 years, with progressive proximal weakness. But in this type of dystrophy, contractures are not that common, at least early on. By definition, patients with Becker muscular dystrophy are able to walk after the age of 16 years, and they do develop respiratory failure after the 4th decade of life. They're also prone to cardiomyopathy, which can be very severe and life-threatening. And if you check their CPK values, they are usually elevated, more than 5 times the upper limit of normal. But in practice, it's very difficult to make the distinction between Duchenne and Becker dystrophies based on the CPK values. And then we have a third phenotype known as intermediate phenotype or outliers, with onset intermediate between DMD and BMD. And these individuals will become wheelchair dependent between the ages of 13 and 16 years, so they're unable to walk after the age of 16 years. They have similar presentation with cardiomyopathy, cognitive impairment, high CPK. But in this group of patients, the neck flexor strength seems to be preserved, as it is, of course, also in Becker muscular dystrophy. So if you ask the patient to lie down on an examination table and ask him to get his head off the table, he's able to do that, something that does not actually happen in patients who have classic Duchenne muscular dystrophy. So we're talking about Duchenne, Becker, and so on, but since the discovery of the dystrophin protein, many clinicians prefer the term dystrophinopathies, which includes a number of phenotypes, not just what I just presented, but also manifesting DMD, BMD carrier females. Somewhere between 20 to 25% of carriers can be symptomatic and have weakness, cardiomyopathy, and muscle cramps, and so on. There is also another phenotype of X-linked dilated cardiomyopathy, in which you have pedigrees of patients who have primarily cardiomyopathy due to dystrophin deficiency, without actually having a significant amount of skeletal muscle weakness. I mean, rarely some patients can have both. And then we have another group of patients who present primarily with muscle cramps and myoglobinuria, as if they have a metabolic myopathy. This is the Duchenne gene we have called the cDNA, and which is very, very large, and it includes 79 exons, and you can see that most of the patients have what we call deletions of the dystrophin gene, which means that a segment of the gene is missing. And most of them seem to occur in the center of the gene and sometimes at the 5' end area here. There is no correlation between the size of the deletion and the severity of the phenotype, because a small deletion can give you a Duchenne phenotype, whereas a larger one can give you a Becker phenotype. So what determines the phenotype? It's really, what determines the phenotype is whether the deletion is in frame or out of frame. Most patients who have an out of frame deletion develop Duchenne muscular dystrophy when the ends of the deletion breakpoints are not compatible. You end up with scrambling of the messenger RNA and therefore a protein from the distal end of the breakpoint, or you may have the creation of a stop mutation downstream, which results in the production of a small molecule which is not functional. Whereas in Becker patients, you can have a larger deletion which happens to be in frame, which means that the ends of the deletion of the breakpoints are compatible in the sense that the codon structure is not altered, and therefore you end up with a protein which is read as dystrophin. It is shorter, but nevertheless it is functional to some extent. As I said, most of our patients have what we call deletions of the Duchenne gene. About, I would say, as many as 60 to 70% of the patients, they have a deletion of number of exons. About 10% have duplications, and the rest have what we call point or mutations or microdeletions or microduplications. Here is a PCR in which a number of exons have been amplified, a number of segments have been amplified, and here you have the normal pattern. And here on this side you have those two lanes. You have two patients who actually are missing a number of those bands, which indicates they have a deletion of the dystrophin gene. So on average, the genetic testing will show deletions in about 65%. It's about 65% in Duchenne dystrophy. It's about 75% in Becker muscular dystrophy, to be exact. As I told you, about 10%, 5-10% have duplications, and the rest have these small mutations, either microdeletions, microduplications, point mutations, splicing errors, 25 to 30%, which can be detected with different methodology. If you do a muscle biopsy, as I said earlier, you get a dystrophic appearance in the sense that there is significant variability in fiber size. Some fibers are large, some fibers are small. You have a lot of connective tissue in between the muscle fibers and between the fascicles. You have inflammatory cells, fibers that seem to be what we call opaque fibers or hypercontracted, as well as degeneration and regeneration also of the muscle fibers. Now, this is a normal muscle biopsy stained with anti-dystrophin antibodies, and you see that you have a nice staining of the muscle fiber membrane in somebody who is normal. And then if you do the same on a biopsy of a patient with Duchenne muscular dystrophy, you find that there is no staining for the dystrophin protein, suggesting that you have absence of dystrophin. And rarely you may have a few fibers who seem to stain positively. Those are known as revertant fibers, but the number of these fibers is really very small. It's no more than 1 to 5% of all the muscle fibers. And this happens because sometimes there might be a secondary mutation that corrects the primary genetic defect, and therefore we have production in dystrophin in some of those nuclear domains. Now, if you do a muscle biopsy on a female patient who is a DMD carrier, particularly in symptomatic females, you find what we call a mosaic of dystrophin positive and dystrophin negative fibers. That's very typical of DMD carriers. But in addition to immunohistochemistry, we can also send a piece of muscle tissue to laboratory to perform dystrophin analysis. And you can see here, this is a Western blot stained with anti-dystrophin antibodies. And these are normal individuals, but you can see some of the lanes give you no signal, a very faint signal. These are from patients who have Duchenne muscular dystrophy. In some cases, you have some signal if a patient has Becker muscular dystrophy, and the size of the molecule can be either smaller or larger in deletion duplication cases, respectively. So what determines the phenotype? As I told you earlier, the phenotype is primarily determined by the in-frame or out-of-frame status of the deletion. Although there are exceptions to that, that's true in about 90% of the cases. But also the location of the deletion is important, meaning that deletions involving the amino terminus, for example, the actin binding domain or some areas in the carboxy terminus, are much more severe, can give you a much more severe phenotype than deletions involving the central rod domain. Also, the quality of the dystrophin protein on the Western blot is important. You can have, if you have a molecule that has a smaller molecular weight in a deletion case, or a larger molecular weight that we have in a patient who has a duplication, that usually happens in patients who have Becker muscular dystrophy. At the end, what really matters is the quantity of the dystrophin protein, how much dystrophin is there. And when you do this test, you get a report that says that this patient has less than 5% of normal. That's very indicative of a Duchenne phenotype. Patients who have an intermediate phenotype, they have between 5 and 20% of normal. In patients who have Becker muscular dystrophy, they usually have between 20 and 50% of normal quantity of dystrophin protein. These are approximations. There are always exceptions to this. And the reason for the exceptions is it may be technical to some extent, but also may be related to the possible role of compensating mechanisms like eutrophin upregulation, or perhaps the existence of epigenetic factors that can modify the phenotype even within two siblings who have in the same family who have the same mutation. We used to do a lot of muscle biopsies in the past to diagnose Duchenne or Becker muscular dystrophy, particularly if the patient had no deletion duplication detected. This is a very busy slide, and it cannot be discussed now in detail, but you can read this if you want to. But the main first step, after you suspect Duchenne Becker muscular dystrophy in a child who has proximal weakness and a very high CPK, usually in the thousands, is to perform DNA analysis using different techniques. We used to use PCR before. Now MLPA is the technique of choice. And if that's negative, then we ask the laboratory to do sequencing of the gene, because there might be a small mutation that can only be detected by sequencing. And once you find the mutation, particularly if it's a deletion and you can you know the in-frame or out-of-frame status of the deletion, most of the time you don't actually need to do a muscle biopsy. In rare cases, you may have to do a biopsy if the results of the genetic testing are ambiguous, or if the family wants to have another confirmatory test. That may be a reason for doing another muscle biopsy. But again, the number of muscle biopsies has decreased significantly during the last 10 years. Now, as far as management, the management is multidisciplinary, which means that these patients have a number of problems, therefore they need to be followed by a number of different specialists in a multidisciplinary environment: neurology, genetics, orthopedics, physical therapy, pulmonary, cardiology, and so on. There is drug therapy, which I'm going to discuss shortly. And we focus a lot on the prevention of secondary complications like cardiorespiratory, with immunizations, with the use of afterload inhibitors like ACE inhibitors for cardiac function once the ejection fraction falls down to less than 55%. Nutritional interventions are very, very, very important. Musculoskeletal issues need to be addressed with physical therapy for the prevention of contractures, and bone health has become very important, and that's the reason for monitoring vitamin D levels and so on. Surveillance, also important. These patients need to be examined periodically by a cardiologist, but also by pulmonary and orthopedic specialists to address cardiac, pulmonary, and orthopedic issues like scoliosis, for example. Now, as far as drug therapy, corticosteroids are really the main medication we use these days in the absence of a curative therapy. It was first suggested by Dr. d.عمر in 1974 and has been shown in a number of studies that using prednisone at a dose of 0.75 milligrams per kilogram per day can be helpful to patients who have Duchenne muscular dystrophy. However, doses as low as 0.5 or even 0.4 may be enough to maintain the effect, but we do start with 0.75. We usually see improvement within 10 days, and after 3 months you have the patient plateaus, you don't see any further improvement, and the effect can be sustained for at least 3 years, but in practice we've noticed it can be sustained for many years. In fact, we continue using steroids even after the child becomes wheelchair dependent. The effect of steroids could be anti-inflammatory, maybe has a membrane stabilizing effect, but we're not entirely sure about the exact mechanism of the steroid effect. There's an alternative steroid known as deflazacort, which is not approved by FDA here in the United States, but it's used in Canada, in Europe, and elsewhere. It's similarly effective. Some claim that it does not induce a lot of weight gain compared to prednisone, but we start with a dose which is 0.9 milligrams per kilogram per day. But the patient has to monitor for cataract formation because it seems the incidence of cataract is much higher in patients who take deflazacort. If the patient has side effects, usually behavioral side effects or significant weight gain, we can apply the 10-day on, 10-day on, 10-day off schedule, which can be successful. But the use of prednisone, deflazacort over the years still hasn't settled the issue as to whether deflazacort is better than prednisone, or whether a 10-day on, 10-day off schedule is better than a daily schedule. And for that reason, there is an ongoing study which has been funded by NIH called the 4DMD study, comparing a number of different regimens with prednisone and deflazacort. Now, in addition to steroids, anabolic steroids have been studied and have been found to be effective, but in clinical practice we don't use a lot of anabolic steroids. At least myself, I haven't used them. But sometimes, if a patient has significant side effects from steroids, we recommend creatine monohydrate in doses between 3 and 5 grams per day, for example. There's evidence that perhaps coenzyme Q10 may have some marginal effect. I'm not convinced myself that CoQ10 is actually effective, but many families who, particularly the child has side effects from steroids, may use a CoQ10 or glutamine. Idebenone is a CoQ10 analog, very similar to CoQ10, and is currently under investigation for use in Duchenne muscular dystrophy, although it is available, and some families already use it, although it has not been proven to be effective yet. azathioprine that has been studied and has not been found to be beneficial. Now, the management of DMD is something that has a lot of details, and we may need an hour to discuss the management of Duchenne muscular dystrophy. So for those who really want to know the details about how we use steroids and all other interventions for surveillance and so on, here's a number of references. One is in Gene Reviews, which was updated recently, 2014. There's also a practice parameter was published in Neurology in 2005. And more recently, there are some CDC guidelines on the diagnosis and management of Duchenne muscular dystrophy published in Lancet Neurology in 2010. These will be good sources for reading for the management of Duchenne or Becker muscular dystrophy. There's been a lot of discussion about other interventions, because as I told you, steroids are not actually curative. In the early 90s, there was a lot of discussion about myoblast transfer by direct intramuscular injection of normal myoblasts, but that was proven to be ineffective. And there's a lot of discussion over the years about stem cell research. And this type of research is still ongoing. Unfortunately, we haven't had a major breakthrough recently, but the efforts do continue in this area. Gene therapy also has been studied extensively during the years since the discovery of the DMD gene using mini or microdystrophins. But nevertheless, we don't have something that can be used in the clinic. There are no large-scale clinical trials right now, only small-scale trials in limb-girdle muscular dystrophies. The three areas that seem to be very promising are is the exon skipping effort with antisense oligonucleotides. There have been two efforts, one in Europe, using an oligonucleotide to skip over exon 51. The oligo is known as Pro51. There's also another effort initiated here in the United States. Again, we're talking about an oligonucleotide that binds to exon 51, known as a teplirsen. There has been an effort to read through stop codons using different compounds. Initially, it was aminoglycosides. Now there's a molecule known as PTC114, which seems to be able to do that, at least in vitro. There are efforts in myostatin inhibition, follistatin, and also follistatin gene therapy that seem to be promising. We did conduct a study recently comparing lisinopril to losartan, and we found that they seem to be pretty equivalent as far as cardiac treatment is concerned, treatment of the cardiomyopathy. And therefore, losartan can be used instead of lisinopril if a patient has a lot of side effects. But unfortunately, losartan did not seem to have any significant effect on peripheral skeletal muscle function. Initially, it was thought to be anti-fibrotic, but nevertheless, we did not find any effect on skeletal muscles. So as far as the oligonucleotides are concerned, the antisense oligonucleotide known as Pro51 has been studied extensively for a number of years, and there are publications like this one in the New England Journal of Medicine describing local dystrophin restoration after injection of Pro51. The idea behind exon skipping is that if, for example, you have a deletion of exon 50, you can see that the ends of exon 59 and exon 51 are not compatible. So when you have the creation of messenger RNA, that cannot be read normally because an out-of-frame messenger RNA. Therefore, you have production of a production of a molecule that is truncated and actually is not dystrophin. Now, if you use an oligonucleotide which binds exon 51, you end up with a situation where the end of exon 49 and exon 52 are compatible, and therefore you have the formation of in-frame messenger RNA, and therefore the production of a protein which looks like dystrophin. It is smaller, but it is there. But nonetheless, it is dystrophin, therefore functional to some extent. This is what happens in patients who have Becker muscular dystrophy. So you can, if this works, you can convert a Duchenne phenotype into a Becker phenotype, and this is an ongoing effort. The preliminary results seem to be very promising, and pretty soon there will be a phase 3 trial here in the United States and also internationally using eteplirsen for the treatment of Duchenne muscular dystrophy. Now, as far as treatment of patients who have stop codons, as you know, normally you have the messenger RNA, which is read by a ribosome, and which sort of goes through the messenger RNA, and the reading stops at the normal termination codon here, and with the production of a full-length protein. If you have a stop mutation somewhere in the gene, the translation of the protein will go up to the stop codon and will not go does not actually read anything beyond that, and you end up with a complete protein which is truncated, and therefore it's not functional. About 13% of the patients with DMD have a stop mutation, what we call a nonsense mutation. There is a molecule known as atalurin, which was designed to overcome nonsense mutations, and allows what we call read-through a stop mutation. So with atalurin, the ribosome can read the entire protein, and you, in theory, you should end up with full-length protein. This has been studied for many years, preclinically, in vitro experiments, and so on, and appear to be a very promising way to treat patients who have stop mutations. A number of studies were done, many of them supported by MDA and other organizations. We conducted a phase 2b study back in 2010, but unfortunately at that time atalurin was found to be safe but not effective in the treatment of Duchenne muscular dystrophy. When they did post-hoc analysis, they discovered that the patients who receive a smaller, what they call the low dose, they seem to have some effect. The company went back to FDA, and a new phase 3 trial was initiated about a year ago with a low dose, 20 milligrams per kilogram per day, which continues to be in progress, and we'll probably know within a year whether the medication is effective or not. So this is the second important effort in the development of some type of genetic molecular therapy for the treatment of Duchenne muscular dystrophy. So let's move on to other types of dystrophy. This is the dystrophin molecule, which is sitting on the inner side of the muscle fiber membrane. You can see here there's a large number of other proteins, some of them associated closely with dystrophin, like the dystroglycan complex here, but also the other proteins known as sarcoglycans, dysferlin, caveolin-3, filamin, integrin, lamin alpha-2. And all these proteins were discovered gradually in the 90s after the discovery of dystrophin in the late 80s. And most of them have been linked to other types of muscular dystrophies. So we used to talk about limb-girdle muscular dystrophy as if it was a single disease, but as time went on, we discovered there are many types of limb-girdle muscular dystrophies, and some of them are autosomal dominant, seen primarily in adults. They usually have a milder phenotype. And you can see the list is somewhat long, with LGMD1A due to mutations in myothelin or defects in myothelin protein. LGMD1B is due to lamin AC deficiency, and this is a form of autosomal dominant Emery-Dreifuss muscular dystrophy. Caveolin 3 is interesting because it not only can give you an LGMD known as LGMD1C, but you may have also a patient who presents what looks like a metabolic myopathy. We can have just benign hyperlipidemia, or we can have what we call rippling muscle disease. LGMD1D due to desmin deficiency, this patient developed cardiomyopathy, and so on. And then we have a much longer list of autosomal recessive muscular dystrophies due to deficiency of all of these proteins that have been localized. The genes can be localized to all these chromosomes. And we're talking about calpain-3 deficiency. A lot of patients have what we call calpainopathy. Dysferlin deficiency is interesting because these patients not only develop LGMD2B, but they can also develop a distal myopathy known as Miyasi myopathy with atrophy of the gastrocnemiae muscles. We also have the sarcoglycanopathies and many other types of autosomal recessive LGMDs. FKRP deficiency is interesting because FKRP stands for fukutin-related protein. And it's interesting because the presentation of a patient with LGMD2I is very similar to the presentation of a patient with dystrophinopathy, in the sense that it can present with proximal weakness, but also in some of these patients with significant respiratory issues, respiratory failure, and also cardiomyopathy. So they can easily be confused, at least the males, with DMD. And as I said, they have proximal weakness. You can see that in a patient who has LGMD, you can have, even as the patient is standing there, you see winging of the scapulars. The scapulars seem to stick out, suggesting there's weakness of the muscles around the shoulder and the scapulas. Very typical of LGMD, but also of FSH muscular dystrophy, of course. The diagnosis of this group of conditions can be a little difficult clinically, although some of them have some distinct diagnostic clinical features. But nevertheless, we get some help from the laboratory because if the CPK is very high, if it's more than 1,000 units per liter, you don't actually have to do any electromyography. It does support the diagnosis of muscular dystrophy, but if the CPK is less than 1,000, you may consider electromyography because other conditions like spinal muscular atrophy can give you a CPK that's less than 1,000. We tend to perform genetic testing. Initially, if we have somebody who has a CPK in the thousands, we have to, if it's a boy, we have to exclude dystrophinopathy, of course. And if that's negative, we do LGMD DNA testing, usually a panel of genes. And if that's negative, we may proceed with a muscle biopsy for histological analysis, but also for immunohistochemistry. This is a case of a patient who has gamma sarcoglycanopathy. You can see the staining for gamma sarcoglycan is essentially absent. There is and there is decreased staining. The staining for alpha and beta seem to be somewhat decreased, but we have normal staining for dystrophin here. Again, these days it is possible to make the diagnosis by genetic analysis. Now, as far as the treatment of LGMD is concerned, it is not a single disease, and steroids have not actually been shown to be effective when they were used anecdotally. I have used steroids in my clinic a number of times, and I haven't seen a significant therapeutic effect. Quite often we use creatine which, as I said, can be used at doses of 3 to 5 grams per day, but with very good hydration, because a large amounts of creatine can be nephrotoxic. There are some reports of response to steroids in patients with LGMD2I due to FKRP deficiency and LGMD12 due to fucotin deficiency. So they have reported a beneficial effect, but nevertheless, these are just case reports, and there are no double-blind controlled trials. And then we move to another group of muscular dystrophies known as congenital muscular dystrophies. And there are two main subcategories here. One is the congenital muscular dystrophy without structural CNS anomalies, also known as classic or accidental muscular dystrophies. And then we have congenital muscular dystrophy with structural CNS anomalies. And the classic ones are Fukuyama muscular dystrophy, Walker-Warburg syndrome, and muscle, eye, and brain disease. The group of congenital muscular dystrophies, the classic group without structural CNS anomalies is quite long. I have to say that this is somewhat a simplistic classification, because even some of these patients have been found to have structural CNS anomalies on MRI. The most common one and the one that was described was delineated in the beginning was primary merosin deficiency due to mutations in the gene known as lamin alpha-2 chain of merosin. But there are also other types of secondary merosin deficiency. Rigid spine syndrome is a type of congenital muscular dystrophy with significant involvement of the axial muscles, resulting in scoliosis, in addition to weakness and respiratory failure. So we're talking about merosin is any laminin molecule that includes an alpha-2 chain can be called merosin. And in merosin deficient CMD, there's a mutation in the alpha-2 chain of merosin, which disrupts the connection between the dystroglycan complex and the extracellular matrix, and therefore the entire complex seems to fall apart. This is a child who has merosin deficient congenital muscular dystrophy. You can see that he has this presentation of a flappy infant with sort of like almost frog-leg position and significant head lag upon arm traction, as happens in babies who have significant hypotonia. Now, merosin deficient CMD is also characterized by other findings. If you do an MRI, the MRI of the brain is abnormal. If you do neuroconduction studies, they also can be abnormal. The CPK tends to be quite high, more than 1,000 units. These children appear to be weaker. They tend to have poor prognosis. Most of them never walk, but there are also mild cases have been described in the literature. Now, every patient who has merosin can be classified under the umbrella of merosin-positive CMDs, although I have to say that over the years, most of them can be delineated at the molecular level. But they tend to have normal head MRI. They do not have a neuropathy by neuroconduction studies. The CPK is only moderately elevated. They tend to have a milder phenotype, and overall they have a better prognosis, although exceptions to this rule can be described as well. So this is a case of merosin deficient CMD or MDC1A. This is a normal biopsy stain with anti-merosin antibodies. And here is a biopsy from a patient who has MDC1A. You can see we don't actually have staining for merosin. This is from another patient. Again, we have a normal control here with very nice staining. This is a merosin deficient case. You can barely see some staining. But you also have, and then you have a merosin positive case. You have the biopsy dystrophic, but nevertheless, you do have merosin immunostaining. If you do an MRI in a patient with MDC1A, it has a pattern of leukodystrophy. You see these hyperintensities in the white matter, which seem to be symmetric bilateral. And if you do a muscle biopsy, it has this nonspecific dystrophic appearance, looks like muscular dystrophy with fibers falling apart, significant variation in fiber size, and also significant amounts of connective tissue in between the muscle fibers and also between the fascicles. I told you that there are also other types of congenital muscular dystrophies without central nervous system involvement. One of them important to mention is Ulrich congenital muscular dystrophy. They used to be known also as a tonus-sclerotic form, presented with generalized muscle weakness. There is hip dislocation at birth, but the main features are really contractures of proximal joints and hyperflexibility, hyperlaxity of distal joints. So you have this paradoxical coexistence of proximal contractures and distal hyperflexibility, in addition to having keloid formation, abnormal scar formation, particularly at the site of muscle biopsy. You may see a very abnormal keloid. Follicular hyperkeratosis, something you see with Ulrich muscular dystrophy. If you take a look at the heels, they seem to be protuberant because the calcaneae seem to be protuberant. These patients do not have respiratory or feeding problems. They don't have normal intelligence. And these days we'll confirm the diagnosis by sending DNA testing for collagen 6 mutations. We find mutations in either the alpha-1, alpha-2, alpha-3 subunits of collagen 6. You can see here you have a patient with Ulrich muscular dystrophy. You can see there is a proximal contracture, distal hyperflexibility. You can really, a lot of laxity, you can hyperextend the fingers and the toes in a child who also has prominent calcaneae here. So this is the a typical presentation of a child who has Ulrich CMD due to mutation collagen 6, which is sitting in the extracellular matrix here outside the muscle fiber. And then we get into the group of CMDs with structural CNS abnormalities. Some people don't like that term. They say CMD with CNS involvement with or without mental developmental delay. But in any case, the main ones are Fukuyama congenital muscular dystrophy, muscle iron brain disease, and Walker-Warburg syndrome. These autosomal recessive types of muscular dystrophy due to mutations in different genes like the fukutin gene in Fukuyama, POMGNT1 in muscle and brain disease, and POMT1 in Walker-Warburg syndrome. But as time went on, we discovered that these dystrophies can be caused by mutations in many of these genes. So you can have, for example, Walker-Warburg syndrome due to mutations in POMGNT1 and so on. And the list of genes has expanded tremendously. As far as the phenotype is concerned, the features of muscular dystrophies, again, Walker-Warburg syndrome, muscle and brain disease, Fukuyama muscular dystrophy, there are significant ocular malformations, including malformation anterior chamber and persistent primary vitreous, for example, in Walker-Warburg syndrome. In muscle and brain disease, you can have progressive myopia. We can also have retinal degeneration. Whereas in Fukuyama muscular dystrophy, you can just have simple myopia without structural changes. The brain also can have different degrees of malformation, and in these muscular dystrophies, as severe as lissencephaly type 2, and as mild as having just an area of microgyria or pachygyria or heterotopias. The clinical course does vary with a very severe phenotype in Walker-Warburg syndrome, and many of these patients die in early infancy. And then we have patients who have intermediate life expectancy, or live beyond the age of 3 years in muscle iron brain disease, and less severe course in patients with Fukuyama muscular dystrophy. This is from a patient with muscle iron brain disease. You can see the brainstem is somewhat flat in the front. The corpus callosum seems to be somewhat hypoplastic. You have hyperintensity in the white matter bilaterally. And then in a patient with Walker-Warburg syndrome, the malformation is even more severe. The brainstem is very, very flat in the front, very thin. There's no corpus callosum, there's a posterior fossa cyst, and significant hydrocephalus. And this from an autopsy specimen, where you see that the occipital area of the brain is essentially flat, and then you have what looks like lissencephaly type 2 or cobblestone lissencephaly in a patient with muscle iron brain disease. If you stain a muscle biopsy with spectral antibodies, you get normal staining even in patients who have FKRP deficiency, which is one of these conditions. The staining for laminin alpha-2 seems to be decreased, whereas if you stain for alpha-dystroglycan, you get no staining at all in patients who have FKRP deficiency or some of the other types of muscular dystrophy like Fukuyama, muscle and brain disease, or Walker-Warburg syndrome. So we're talking about conditions which have to do with the glycosylation of alpha-dystroglycan. As you can see, the molecule has some glycan epitopes on top of it, which are very, very important because without these epitopes, without these molecules, the binding between alpha-dystroglycan and myrcene becomes compromised, and therefore the whole complex falls apart, if you have deficient glycosylation of alpha-dystroglycan. So all these conditions are basically are glycosylation defects. And if you stain for alpha-dystroglycan, as I said earlier, with a particular monoclonal antibody, you don't actually find a lot of alpha-dystroglycan there. Now, if you stain with a polyclonal antibody, you do see normal staining. This is the name of the antibody, which is monoclonal, specific against. It is specifically designed to bind to glycan epitopes on the alpha-dystroglycan molecule. So in all these conditions, as I said, the alpha-dystroglycan is underglycosylated, and all these proteins are basically putative or proven glycosyl transferases. So these enzymes, if they're not present in large amounts, if they're defective, they lead to deficient glycosylation of alpha-dystroglycan, and therefore the staining, the binding with myrcene becomes compromised, and the whole complex falls apart, which creates muscular dystrophy. And then we move on to another condition. You see there is a girl here who seems to be okay, when she's not trying to close her eyes. So there's a little bit of lower facial weakness. You can see here that you have, when you ask her to close her eyes, they don't close totally. And if you ask one of these patients to push against the wall, you have significant scapular winging. So the scapulars, they tend to stick out because the muscle around the shoulders, they seem to have atrophy and weakness. So this is known as facioscapulohumeral muscular dystrophy, or if it says muscular dystrophy. This is an autosomal dominant condition with onset in early childhood to adult life, which presents with facial weakness. You have significant shoulder girdle weakness, as I said earlier. They tend to have lordosis and pelvic girdle weakness. They have proximal weakness around the hips. They may have sensorineural hearing loss, but also retinal changes, which a particular retinopathy, which is a microangiopathy known as Code syndrome. And the course, of course, varies depending on the severity of the disease. This particular condition was mapped to the tip of chromosome 4q, where there appears to be a repeat segment known as D4Z4. So you have a repeat RA, which in patients with FSH muscular dystrophy appears to be contracted. So in this case, we do not have expansion where it appears that happens in other conditions. Here we have contraction of this repeat with patients who have FSH muscular dystrophy having between 1 and 10 copies of this particular repeat. Patients who are normal, they have between 11 and more than 100 copies of this D4, Z4 repeat on the tip of chromosome 4. So the pathogenesis is quite complex here. It cannot be described very easily within a couple of minutes. But in summary, I have to say that FSH has a high degree of de novo mutations, about 30%. There's a high percentage there of de novo mutations. There's also somatic mosaicism, which means that you can have a milder phenotype because of this mosaicism. Some of the tissues have the mutation, some others do not. And the way we make the diagnosis is usually by sending blood to a laboratory where the DNA gets extracted. And what they do, they cut the DNA with an enzyme known as EQR1 and probe it with a probe known as P13E11, which can detect that area of the repeat array. Normally, this fragment should be more than 41 kilobases, which means we have more than 11 copies of this repeat. In a patient who has FSH muscular dystrophy, 95% of the time you find that this fragment is between 10 and 38 kilobases, which corresponds to 1 to 10 copies of the repeat. Then we have a borderline range between 35 and 30 kilobases, which intermediate, sometimes the phenotype can be unpredictable. We do know, however, that if you have a very small fragment, like 1 to 3 copies of the repeat, you usually end up with severe disease, we call congenital FSH muscular dystrophy. Now, there are patients who have contraction of this repeat and did not have FSH. The reason for that is that, one reason for that is that in order to have development of FSH muscular dystrophy, this has to happen on a background of a 4QA haplotype, and that area has to be hypomethylated. In about 5% of the patients who do not have a contraction, how does FSH happen? In those patients, it was found that both copies on both chromosomes, this repeat array seems to be hypomethylated. And this is known as FSH-D2. So patients who have the classic type of FSH-D due to contraction of the D4, Z4 repeat are classified as having FSH-D1. And patients who have they have no contraction, they have hypomethylation, are classified as having FSH-D2. It was found a few years ago that this repeat contains a gene known as DAX4. And the reason for the development of muscular dystrophy is that when this particular gene is expressed, or the expression is facilitated by polymorphisms in that area of the permissive haplotype that allow the transcription and translation of DAX4. So you have production of DAX4 protein, which seems to have a toxic gain of function effect and creates muscle injury in patients who have D4, Z4 contraction, FSH-D1. Another gene was discovered a few years ago known as SMACHD1, which also creates muscular dystrophy if it is mutated. I don't have the time to get into details, but both of these conditions result in a relaxed chromatin structure, which allows the expression of DAX4 and therefore the generation of muscular dystrophy. We say both mechanisms, I mean D4, Z4 contraction or mutation in the SMCHD1 gene. Now, here we have another patient who seems to have, this girl has myopathic face, has ptosis, has significant atrophy of the muscles, temporal muscles, a little bit of masseter, the open mouth. This is myotonia dystrophy. This girl has myotonia dystrophy type 1, DM1, There's also congenital myotonic dystrophy, DM1, but also DM2, known as myotonic dystrophy type 2, or proximal myotonic myopathy. This is another patient who has DM1. You see there's significant ptosis, and the face seems to be myopathic. Adults with DM1, they have, in addition to having a myopathic face, they have significant frontal balding, atrophy of the temporalis muscle, but also atrophy of the masseteres and the neck muscles as well. This condition is due to expansion of a repeat, of a CTG repeat on chromosome 19. Normally we have between 4 and 37 copies. Patients we have DM1, most of them have they have more than 50 copies of the CTG repeat, and definitely more than 100 once we have the classical presentation. So patients who have classic DM1, they have between 100 to 750 copies. Babies who have congenital form of the illness, they have more than 750 copies. We see sometimes babies in the neonatal intensive care units who have congenital DM1. These are infants who are born to mothers who have myotonic dystrophy. 15 to 25% of the patients born to myotonic dystrophy mothers, they develop this congenital form of the illness characterized by low muscle tone, poor feeding, weakness, not only of the face but also of the extremities, club feet, and also developmental delay. If you check the CPK, it's usually normal, and we don't actually find myotonia even by electromyography, but we do find an expansion of a CTG repeat of chromosome 19 by DNA analysis. So this is an infant who has congenital DM1. You can see they have this typical inverted V upper lip. They have, the face is myopathic. They have a club foot. They have weakness, which seems to be, it's not as striking as it is with other muscle diseases. If you take a look at the forearm, in an older patient who has DM1, you see there's some atrophy of the distal muscles of the forearm, and also you see the thinner eminence is quite atrophic. So this is a muscular dystrophy that presents with distal weakness instead of proximal weakness we see in the majority of patients who have muscular dystrophies. There's also myotonic myopathy DM2, which is a little different from DM1. There are of course a lot of similarities, except that you do not see congenital form DM2. We don't see infants who have DM2. There is lack of mental retardation in juvenile cases. They tend to have less central hypersomnia. They have less distal facial bulbar weakness. They have less pronounced muscle atrophy. And the age at onset is between 13 and 67 years. And these patients have an expansion of a repeat in intron 1 of a zinc finger protein, a gene known as ZNF9. In both of these conditions, the pathogenesis is similar. These expanded polyglutamine RNAs, they tend to be very sticky, and they seem to exert a dominant toxic gain-of-function effect on other genes by sequestering a number of essential RNA-binding proteins, like the muscle-binding protein and many others, and therefore by resulting in aberrant splicing of different genes. So the mechanism is similar, and has to do with compromised splicing of, let's say, the chloride channel gene. This is why I have myotonia. Alpha-dystrobreviin, for example, or insulin receptor gene gets spliced in an abnormal way. Therefore, this is why you have insulin resistance, and also cardiac troponin T. This is why they have cardiac issues. And then the last form of muscular dystrophy I would like to describe today is this one, where in childhood, the muscle biopsy does not look very abnormal, but it does have an X-linked pattern of inheritance, meaning that boys is only affected. If you ask the child to bend down, touch his knees or his toes, he has a hard time doing that because they have significant stiffness in the lower spine. They can extend the neck, but they have difficulty bending the neck forward. And as they get older, they develop these typical elbow contractures with atrophy of the biceps and triceps. And if you do an EKG, you may find they have different arrhythmias, but classically develop AV block, which can be lethal if a pacemaker is not inserted. And as time goes on, you have the biopsy looks more and more dystrophic. It is an X chromosome-linked recessive condition, but also it can be autosomal dominant with onset in late childhood or adult life. You can have fixed contractures at the elbows and neck, as I told you earlier. The weakness tends to be humeral peroneal. They can have bad cardiac arrhythmias or AV block, but it does have a slowly progressive course and has been linked to mutations in genes like emerin on the X chromosome and lamin AC for the autosomal dominant or even recessive cases, but other genes like Nesprin1, Nesprin2, FHHL1, and LUMA have also been linked to Emery-Dreifuss muscular dystrophy. And all of these, with the exception of the FHL1 gene, are inner nuclear membrane proteins. So all of these proteins being produced are localized on the inner side of the nuclear membrane, forming, for example, lamin AC forms a polymer on the inner side. And this is why they're known as nuclear